We're going to call this meeting to order at 1:30 here this afternoon. Councillor Carlson, I see your hand is up. Do you have a question before we begin?
Yes, I was just going to nominate Councillors Campbell, Schmidt, Rempel, and Palladino for chair and demand 2-minute speeches and a secret ballot vote.
Perfect, thank you. We'll keep that on the note here for item 2.1 and go through there. So before we begin, call to order at 1:30 this afternoon. I'll read the acknowledgement statement. The City of Lethbridge acknowledges that we are gathered in the lands of the Blackfoot people of the Canadian Plains and pays respect to the Blackfoot people past, present, and future, while recognizing and respecting their cultural heritage, beliefs, and relationships to the land. The City of Lethbridge is also home to the Métis Nation of Alberta, Region 3. And with that, I'm going to call for a roll call. Councillor Campbell.
Present. Councillor
Carlson.
Hello.
Councillor Palladino.
I'm here.
Councillor Schmidt-Rempel.
Present.
Excellent. Also online, we have Councillor Croson and Mayor Higgin as well. Numerous guests from Alberta Health Services, Alberta Health, as well as Mr. Vanden Heuvel from the City of Lethbridge in the room, Mr. Fox, Mr. Cool, Mr. Dalton, myself, Ms. Brown. Now we're going to move to the election of the chair.
My nomination stands.
Excellent. We've received 3 nominations. Councillor Carlson has nominated Councillor Campbell, Councillor Schmidt-Rempel, and Councillor Palladino. Do we have any acceptance for those nominations?
I'll accept the chair.
Okay.
I will. If you want to vote on it.
We have an agreement to one. Do we have any other accepting?
Excellent. Then I move nominations cease.
Excellent. Nominations cease. Congratulations, Councillor Campbell. You are now the chair. And then we'll do the election of the vice chair. Do you want to carry forward?
Sorry?
Vice chair. We're going to do the election of the vice chair.
Okay.
Would you like to do it?
Sure. I nominate Jen Schmidt-Rempel as vice chair.
I second that.
Any other nominations? Okay. Nominations are ceasing. All right, Councillor, you are vice chair. Thank you. I turn the chair over to you, Councillor Campbell.
Thank you, everybody. An honor to be on this committee, and we'll continue on with the adoption of the agenda. Shall we do that? Can we do that by consensus? Is there any opposed? Then accept it as such. And the consent agenda, we'll accept that as consensus as well. All in favor? That's good. Continue on. We'll begin with presentations. I understand we have the family medicine situation in Lethbridge here, and welcome. Who do we have? We have, maybe introduce yourselves.
Sure, we can do a quick round of introductions if you like. We'll kind of just go in order because I'm not seeing the participant order on my screen right now, but I'm Mike Ald. I'm Associate Zone Medical Director for Chinook Hospital. Colin, you're looking next to me on the screen, so maybe you go next.
Okay, thank you. Colin Saber, I'm one of the senior operating officers in the South Zone and work with the primary care teams. Thank you.
I can jump in, sure. I'm Andrea Schultz. I'm the Executive Director for Chinook Primary Care Network.
Garland, do you want to go next?
Yeah, I can introduce myself. I'm Dr. Garland Yonker. I'm a family physician in town, and I am the section chief for the community family physicians in town. through the Department of Family Medicine.
Great. Thank you all for being here. Before we get started, I see Councillor Carlson. Do you have a question to start things off here?
Sorry, Mr. Chair, mine was on the consent agenda, but I can raise it after our guests have presented.
Thank you. So I will turn it over to our esteemed panel.
All right, thanks. So I believe the slide presentation is loaded up. So if you're able to start that, and then we'll just give the direction as we go along to advance the slides. So together we represent Alberta Health Services, medical and operational leadership, and then also the Chinook Primary Care Network and the Family Physicians of Lethbridge. And so really those three entities together are the partners in working on our problem with not enough family doctors in Lethbridge. And we've been doing a fair bit of work, and we're excited for the opportunity to talk to the council about the work we've been doing today and talk about what we think are some opportunities to work together with you. So if I can go to the next slide, please. So what I want to do is turn over to Dr. Yonker to really talk about what's the role of family physicians, and then between himself, and I don't know if Dr. Byers has made it on yet. I think we might have, oh, you're here, okay.
I am here, I apologize, I can't get my camera to turn on, but I am here.
Okay, great, thanks, welcome Susan. Susan Byers is our medical director for the Chinook PCN. So together they're gonna talk a little bit about the part that they know best, the shortage of family doctors. So I'll turn it over to you, Garland and Susan.
Sounds good. Thanks everybody for letting us visit with you today. So I'm just going to set the stage here for what optimal primary care ideally looks like, and give a sense of how optimal community health benefits every aspect of our community's function. So first to note is that family physicians represent the first step in assessing and accessing general health care for anyone in the community that's not an emergency presentation. And following this first encounter, family physicians represent the hub and center of all subsequent medical pathways taken. A rough estimate, guesstimating you need maybe a family physician for every 1,000 or so people in the population. This rapidly indicates that family physicians make up the largest population of medical providers in our community and manage an enormous range of community health needs as a result of that. This includes and is not restricted to all primary preventative screening and subsequent management across the lifespan, such as breast cancer, cervical cancer, colon cancer, and so on. It also includes all the rest of the span of healthcare, including hypertension, diabetes, heart disease, and so on. So if you name it, family medicine is involved in some degree in screening and management of our population's care and health. All areas of acute and chronic illness management fall under the family medicine umbrella, as does mental health and addictions, low-risk obstetrical care and delivery, as well as care for patients in long-term care facilities, palliative and end-of-life care. Family physicians are also involved in inpatient care to certain degrees, surgical assist, chronic pain management, sexual assault assessment and care, and the list goes on. Furthermore, access to all specialist levels of care requires initial triage through a primary care physician for efficient and appropriate use of the system. So clearly, family physicians are very critical in maintaining an ongoing healthy community in all respects. We don't accomplish this job in isolation. This is done with collaboration. AHS facilities, programs, emergency specialist care are all vital to our ongoing work with the community, as well as a partnership with the primary care network, which has been essential over many years of the primary care being in existence in establishing what we consider the gold standard in primary care, which is called the family medical home. I'm going to hand over the next slide here to Dr. Susan Byers to outline a bit better the role of the primary care network in family medicine and family medical practice.
Thank you, Garland. So Chinook Primary Care Network is, for those of you who don't know, we're a partnership, a joint venture between family physicians in the area and Alberta Health Services. Our network comprises 16 family physician clinics in Lethbridge, and then 14 from rural communities in surrounding areas. Our goal is to provide comprehensive collaborative primary care services to the population in our area. The PCN receives funding directly from Alberta Health, and that funding is primarily used to pay for the multidisciplinary teams that work in our participating clinics. The network focuses mainly on quality improvement, trying to improve access and patient care for the entire population of the area. Next slide. I hand it back to Dr. Yonker.
So this slide is going to outline for us what our current sort of challenge is. So the partnerships that family medicine practitioners in town have with primary care network and with support from the AHS has allowed family medical clinics in Lethbridge and the South Zone to experience what I consider to be a golden age in primary care for the last 15 years or so, by allowing us to develop this family medical home model. Patient metrics in our area and long-term health outcomes of our population are at a standard that are the envy of other health regions. They're the envy of other provinces, and other health systems in the world look to our area to guide on how to manage primary care. Clinics in Lethbridge have benefited from this very effective model by being able to retain for many, many years full contingents of family practitioners, and also a regular influx of medical trainees and residents that represent future primary care practitioners, and a consistent and ongoing expression of interest from physicians from outside of our system that are interested in practicing in the area, which means that there hasn't been a need in our area, our community, for many, many years for a collective or a collaborative driven recruitment and retention strategy to bring interested family physicians to the area. The clinics have had a very robust practice, extremely successful efforts at managing our population health, and therefore have been recognized as a very valuable place to come and set up practice and to establish your care in your clinic. It's worth noting that most rural communities, in fact, have a community-run organization that recruits full-time for a community. In a smaller center where there are fewer physicians, they recognize that losing 1 or 2 physicians out of a very small number would be very devastating to that community's well-being. But in Lethbridge area, we've had such a robust practices for so many years that we haven't had a need for a community-driven strategy to help bring in interested family physicians. This has almost largely been done simply by the clinic's successful operation and by the clinics making some efforts to recruit themselves. This is not our current situation anymore, though. We're in a significant crisis situation in terms of our numbers of family physicians. We've had a very large exodus of family physicians from Lethbridge over the last 18 to 24 months or so, which we'll get to in a further slide here. The reasons are layered, and I won't review them all here. But the fact that we need to address and that we're trying to develop some further collaboration over is that we no longer have enough family physicians to continue maintaining the family medical home model in all of our clinics in the city. And as that family medical home model starts to collapse, which we're seeing, patient care is becoming increasingly compromised, and vulnerable and at-risk patients are even more compromised. And very clearly, if a clinic itself collapses in terms of its care model and the family doctors depart, then all the patients that are part of that clinic get cast out into limbo to be cared for somehow in the community without actually having a primary care clinic to attend anymore. And that's the current crisis that we are facing. And I'm going to pass it on to Dr. Byers to outline a bit better what the numbers are that we're looking at here.
Thank you. So next slide. Yeah. So just to give you a better sense of exactly what the problem is in our community right now, we just do not have enough family doctors in Lethbridge. So these numbers are the Chinook Primary Care Network participating physicians over the years. So this is not just Lethbridge, this is includes our surrounding communities. But as you can see, we kind of had a peak of doctors in late 2019, early 2020 at 153. Our projection for the end of December this year is 129 physicians. So we're currently at 131. As you can see, the population in the area continues to grow, and the number of patients who are unattached, so don't have a family doctor to call their own, has risen quite dramatically. So next slide. Just going to break this down so that you can see the Lethbridge numbers compared to our rural clinic numbers. So the scales on these two graphs are different, so you do have to look at the numbers. So in Lethbridge, we're down 21 family physicians from that peak of 88. And in our rural communities, we're down 11 physicians in the same time period. So that's quite a significant change. At this point in time, we have no family physicians in Lethbridge who have room to accept new patients. They can't, they're at their limit of their ability to provide care for the number of patients that they have. They can't take on any more. So every time a physician leaves, that 1,000 to 1,500 patients that they've been caring for become what I call orphaned. They no longer have a family doctor. There is no one for them to go to. They cannot access the healthcare system by any way other than the emergency room. And it's really not the care that they need unless they have an emergency, which is not most of the visits. So next slide. And then this graph just shows you the change in that unattached population over time. So it's going up quite dramatically, and those patients just have nowhere to go when they get ill. A lot of them have chronic diseases, diabetes, heart disease, and they can't get follow-up care or prescription refills even. So it is a huge crisis for our community. So we really need to work together to try to find some solutions and ways to recruit doctors so that we can look after this population.
And Dr. Byers, can we just point out the x-axis there? It's 40,000 we're looking at?
Yes.
What's our
over 40,000 people. So this is Lethbridge and surrounding area. So that title is actually not quite accurate. This is not just the city. But we do know that a lot of patients from rural communities see family physicians in the city and vice versa. So it's really hard to pull those numbers apart. Which patients are in the city and which patients are from rural communities. Okay, next slide, I'm going to pass it on.
Sure. Thanks, Susan and Garland. So I'll take the microphone again for a little bit here. I was remiss, and while Susan and Garland were speaking, I was able to pull up the participant list, and so also want to introduce Dr. Tulani Mitsali, who is our family medicine department head and our colleague, and we're going to be leaning on Dr. Mitsali a little bit later in the presentation when it comes time to talk about some of our solutions, particularly with respect to innovation. So we've been working on this for some months now, and we would like to be able to say we've made much more progress than we have, but essentially we've been doing all that we can to recruit family doctors in order to correct that deficit. What we've got is in recent couple months, one family physician, Canadian trained, has been recruited into Lethbridge, and we have, because a position has been posted, largely the majority of applicants have been international graduates, and they're fantastic. With them also come some unique challenges. So we'll be talking a little bit about the distinction between, I guess, our strategies for attracting Canadian physicians and our strategies for attracting international graduates. We're in the process of interviewing, and we've got approximately between 4 and 9 international graduates who we would be ready to get to our next steps with. So if I can go to the next slide, I'll just talk about what are some of those differences and how are we approaching this problem. As Garland had mentioned earlier, the numbers of really, it's a whole variety of reasons that the physicians leave the community, and not that surprising. The big problem that we've had is the lack of replacement for those physicians who've left, and that's, again, that's not without the clinics trying to recruit physicians. it just hasn't, for a variety of reasons, hasn't seemed to have worked in recent years. So when we recruit those physicians, what we need is, unlike within an AHS facility where we essentially have the facility there ready for people to work in, the physicians need a clinic to come to in the community, and that's really part of sustaining the practice. So if we were to estimate our numbers needed, 20 to 30, and the reason I talk about the difference between international graduates and Canadian physicians, both are an excellent source of physicians. It's important to know that there's the clinics could have been recruiting Canadian physicians all along, and just haven't been successful in doing that lately. So then we posted a position open to sponsorship, and that's the reason for AHS's involvement. AHS needs to sign off on sponsorship. So essentially we need to do those through our recruitment process. And the other important thing to know about the international graduates is that they require a period of assessment before they can start work. So if we had a Canadian graduate show up today looking for a job, then we would be able to, within a very short time, get them up and running. There's a whole variety of checks and balances, and of course having your medical, your license from the college, etc. However, we could get them going within a period of a few weeks. For an international graduate, we're probably looking at realistically somewhere between 6 and 12 months, probably about 8 months before one can start, if there's no hitches in that assessment process. So that's important to know about as we talk about the problem and the fact that, okay, potentially we could hire 9 physicians out of our pool of applicants that we've got right now. So we can go to the next slide. The reason I want to just highlight some of the AHS side of the problem that Garland and Susan have been talking about. And of course, AHS typically, we don't do primary care, but we're very dependent on it. And I'll be able to show you just some of the impacts that it's having with respect to the services we offer at Chinook Hospital within AHS. So one of the things we're going to emphasize is the emergency department for a few reasons. We're also going to talk about all of our other services, because we recently had a chance to talk about the shortage with all of our department heads and get their feedback on what's happening. And then finally, the other big part where AHS gets involved is that we've got some special populations that we don't want them to fall between the cracks. And so we assist in making sure that their care needs are met. So if I can go to the next slide, please. So talking about emergency department, it's the reason that it's important is that if we don't have enough family doctors, our patients often wind up there to get their care needs met. There's a few things that happen then. First off, it's not the best place for patients to go. It strains the system for the people who do need to be in the emergency department, because essentially they're just backed up with too many people. And also it's the backup plan for, it's always there if somebody needs medical care and they don't have a doctor or a clinic's not available, then they can go to emergency department. But it's important to know that to some extent we don't have a third option, and we're straining the system to the point where we're becoming concerned about maintaining our physician workforce within the emergency department just because of the additional workload. We think, when we look at our numbers, that about 10 to 15% of the people who come through an emergency department, our emergency department in a day now, are unattached patients. So if I can go to the next slide, please. These are the numbers, and it's not a very clean graph, realizing that we've had 4 waves of pandemic in there, and that impacts emergency department visits. But essentially, our emergency department visits are up about 7% since back in 2018. That may not seem like a lot, but it's easy to tip the balance in the emergency department. And when we look at all the other critical services that get offered, and just the fact that that what I've been told is that it just backs everything up. So where it didn't, one example is it didn't used to be an issue that ambulances and paramedic teams had to wait at our emergency department. It really wasn't even measured because it was never an issue. When the ambulance came in, the patient was brought in, where now sometimes we have prolonged waits where that does two things. First off, the patient isn't able to get into the emergency department to get the full care that they'd be provided in there. And in addition, it takes one ambulance off the street while they wait to get that next patient into the emergency department. So that's a new phenomenon, part of that sort of 7% increase. So if we can go to the next slide. This is just a dashboard that's been created so that we can really measure and demonstrate the problem better, and more importantly, demonstrate the impact as we start to fix it. And you can see essentially the columns go across by year, and on the right-hand side, for the various measures we have, including the average visits, but also something called family practice sensitive conditions, and the number of people that left without being seen. Those are all markers of an emergency department under strain, where you don't have enough family physicians. And you can see where we've got much more red on the right-hand side, the 2021 column. So if I can go on to the next graph, or next page, slide, pardon me. So we're going to talk, what about the impact on some of the other services within the hospital? And I think we have 10 different medical departments, and not one department had missed, and essentially when we went through the list of things that are impacting them, they all are impacted. And so our general surgeons, for example, in their breast cancer clinic are getting mammogram results that really should be going to primary care. Our internal medicine physicians are hanging on to some of their sicker patients that normally they would send out to a family doctor in the community, but there isn't one for them to go to. Same for our pediatricians. Our obstetricians are concerned because we've also had a loss of low-risk obstetric providers, which are family physicians. And so they're taking on additional workload of obstetrical patients that they don't think is going to be sustainable in the long run. To some extent, what do people do? Well, they rely on physicians in other locations. So some of our population are going to be going out to rural communities, traveling to Calgary. There's maybe some potential for them to go to Medicine Hat because they are part of our zone, but really Medicine Hat is really just holding their own right now with numbers of physicians. So it's not like they have a whole extra amount of capacity. I highlighted in green here just because when we get to the solutions part of things, which we do want to talk about solutions, not just the bad news of not enough physicians. One of the things to keep our eyes on is the potential for virtual care, which we've learned more about during the pandemic. There's how effectively we can get patients into the services they need with effective patient navigation. And then sometimes there's looking at, as I've mentioned with all of our specialists in the hospital, having other providers provide care. What we'd like to do in the long run is make sure that that's the best choice for the patient. So we go to the next slide, please. And these are the people that we know have unmet needs. And in each case, this is where Colin Zieber and myself, we spend a lot of time thinking about how we'll meet the needs for some of these services, and the rest of the leadership team works on it as well. So we know that we're doing some focused work on chronic pain patients. Child and adolescent mental health needs a lot of work. Same for addiction medicine, really the same for all of these. We need to, the corrections facilities normally are able to put out an expression of interest and say, are there any physicians interested in working here? In this case, and really haven't had problems before in getting a family doctor to cover them, but they're also struggling. So if I can go on to the next slide. As I alluded to, there is a light at the end of the tunnel, and we do want to talk about solutions. So we've come up with some ideas. We want to really just present some of those ideas to this group today, and then have a bit of a talk about how we can work together. So the ideas we've come up with are their ideas have been tried elsewhere and sometimes been successful, and then some of them are unique to us. We think that one of the things we should look at and talk about is recruitment incentives, both direct and indirect. We should talk about those, making those helping to make those physician practices sustainable. As Garland had talked about, there's some challenges, so can we help overcome them? Innovation, and we'll get Dr. Mitsali to speak to that a little bit, and then a little bit more detail on what we could do for patients with unmet needs, and then also knowing that not just physicians, all healthcare providers have been through a really tough couple of years. So how are we going to support our physician workforce so that we not only are an attractive place to recruit to, but also we're able to retain our physicians and keep them well so that they can look after us all. And then any other ideas that this group might have. So with that, I'm going to turn things back over to Susan and Garland, and they'll talk us through those first couple of ideas or possible solutions.
Perfect. So if you can go to the next slide. So as Garland had mentioned earlier, larger communities like Lethbridge haven't had a lot of problems with recruiting physicians in the past or historically, but we know that our rural communities really have always had a lot of challenges in recruiting physicians to come, and they've had success with many types of incentive programs. So both direct incentives like providing recruitment bonuses, covering moving expenses, other cost reimbursements like licensing fees, insurance costs, things for physicians new to the province. All of those strategies can help provide some incentive for physicians to choose Lethbridge over other communities. There are also some indirect ways to incentivize physicians to come. So providing housing for them and their families when they first move here, providing some in-kind office space or other practice supports. Some of the strategies that we think we can really link and collaborate with the city and other community groups on are those kind of incentives, marketing strategies for Lethbridge as a city, trying to make it a great place for physicians to come. We've also been having some discussions with the University of Calgary. There are some residency electives, so that's physicians in training who come and work with physicians in the community. We're trying to increase the number of those physicians in training that are coming to Lethbridge so they can learn about the city, learn about practice in Lethbridge, and hopefully come here when they graduate and are finished their training. So lots of different strategies. It's really hard for any one of us, whether it's the PCN, community physicians, or AHS, to do these kinds of things on our own. So this is where that collaborative approach and a community-based approach might be more successful. So I'll turn it over to Dr. Yonker.
Next slide, please. So this slide, I'm going to keep focused on how we keep physician practices sustainable, and not practice in terms of the medical skills, but in terms of the actual business model that clinics run under. So although clinics benefit very clearly from primary care network partnerships and from collaboration with AHS facilities and resources, fundamentally the actual model of primary care is an independent business model, meaning that they're responsible for their own economic operations, operational costs, and so on. So for example, a new family physician that comes to town has to locate and rent space to work in, hire staff, buy equipment and computers, and so on in order to begin seeing patients. These costs and investment in beginning a primary care clinic can be managed by working in a larger group and sharing overhead and business costs, which most and many clinics do. But it also means that these costs become unmanageable without a sustainable physician pool in town. With our current deficit of docs in town, we're now starting to see clinics shuttering doors, closing down locations, and we're starting to see quite a bit of lateral movement of physicians in town looking for less expensive space to work in, or a version of collaborative group practice that will allow them to better sustain their long-term practice. we're getting close to a critical mass where we're getting that domino effect where individuals that are trying very, very hard to stay are actually starting to become impeded by the cost of maintaining their practice, and we may lose docs that are in fact trying very hard to stay here. From my side of things, in terms of this presentation, I think the first and most important immediate next step is to attract new family physicians to the region. Clearly, we need to have some momentum in bringing new interested individuals to the area, and I feel that a collaboration with City Council on some sort of recruitment and retention strategy would be invaluable in this regard. We've already sort of initiated a certain amount of a marketing plan and resources by partnership with Choose Lethbridge and with some input from the Chamber of Commerce. So materials are already being developed, but we still need some proper sort of team or leadership to move this forward properly, and certainly would welcome some guidance and assistance from City Council on this. Sustainability in the long term of things also requires strengthened partnerships with leadership at the local, regional, and provincial levels in order to promote best primary care practice and longevity in maintaining and in order to help us maintain ongoing professional dialogue with all of the parties involved in primary care and in healthcare. And we certainly feel that building this relationship with City Council is key to moving forward here. And this may lead eventually to other discussions around sustainable family practice models, such as alternative remuneration, physician compensation models, and so on. But I feel like that sphere is beyond our immediate need of trying to bring people in, but certainly something that needs to be talked about in the long term. And I think it goes back to Michael from here. Is that right? Yeah.
Yeah, and I will turn it over to Mitsali, because he's been really instrumental in looking at some of our means of innovation and in solving this problem. And so if we can just go to the next slide and take it away, Tulani.
Okay, good afternoon, everyone. Thanks for inviting us to this meeting and for showing interest in helping us to resolve this huge problem. In addition to some of the things that my colleagues have already alluded to, like the virtual clinic, which we're about to launch and will help us to be better prepared to follow up patients being discharged from the hospital or the ED who have no family physician. We are already thinking about long-term strategies. And our main long-term strategy is to expose doctors in training to Lethbridge. It is very rare for an individual to come and work in a place that they've been to or even heard of. So we think that Lethbridge is a wonderful place to not only to work in, but to live, to play, and do all kinds of things. So we do want everyone to share in all this goodness. Our long-term plan is to expose the residents or the doctors in training to Lethbridge repeatedly, and hopefully they'll stay in Lethbridge. Over the course of the past year or so, we've been profiling what a young Canadian trained physician looks like. What are some of the things that they like? How do they like to practice medicine? And we have determined that they don't really like to see too many patients. They'd like to have the ability to, instead of looking after 5,000 patients, they would prefer to look after plus minus 1,000 patients. They would like to have the ability to participate in other services, which, by the way, we can offer them in the hospital. And they also don't like to be running businesses. They just want to be physicians. Therefore, we have thought very deeply about building a clinic, a turnkey style clinic, where they can just come in and practice and not ever have to worry about running the clinic. And we want to do this very creatively, such that the costs of running the clinic are as low as possible, and therefore the cost to the physician is accordingly low. So we're still brainstorming on how to get that done. My gut feeling is that there's a lot of resources in the city to get this done. Our other long-term ambitious project is to establish a family medicine clinic, which is a clinic where young physicians are trained. And we are working very closely with the University of Calgary to get this done. When Calgary and Edmonton were in the same situation as Lethbridge years ago, they came up with an academic clinic, and it solved their problem now. Today they have a surplus of physicians. It's very complicated. It's a multi-million-dollar project. A lot of people have interest in it. We are inviting anyone who has interest in helping us out with this to please join us. There's nothing set in stone yet, so please be part of this project in whatever way you can help. So those are some of the long-term strategies. In terms of what we can do immediately, we can definitely move ahead with the virtual clinic. We are told that there are Canadian-trained physicians already. And as I said before, Calgary has a surplus of them. We've been working very closely with the AMA, and they tell us that they do have a surplus of physicians. And typically, the AMA rural program does not work well for our city because we are regarded as urban. It's a program that's reserved for rural areas. But the AMA have advised me that they can make an exception for us and bring those docs to the city to help us out urgently. But we would have to, pay some. We would have to incentivize those physicians somehow. I can provide you with more details on that. But the bottom line is that the physicians are there with a little bit of investment and incentives. We can bring a number of physicians to stabilize those clinics. Thank you.
All right, thanks, Tulani. And I'll just wrap up with our other two ideas that we've got. If I can go to the next slide, please. And first off, we talked a little, gave you some of the listing of patients with unmet needs and some of the ones that are more difficult to look after. Because they're more difficult to look after, then when we've got a shortage of physicians, there's risk that they fall between the cracks. And getting the care for them can be more challenging. So again, some of it goes back to the innovation. Some of it goes back to finding different ways to attract and compensate physicians to work in special clinics where we look after people. And again, examples being whether it's addiction problems or chronic pain problems, or some of the people with medical complex needs, and certainly Indigenous wellness is a big area in our community as well. And oftentimes, what we find is it's AHS can be part of the solution, but not all of it. And so we need to bring other stakeholders into the work that we do. to support the care of some of those vulnerable individuals. And that can be everything from housing, where we locate our clinics. It can intersect with law enforcement, et cetera. So those are some really important areas for us to consider. If we can go to the final slide, in some ways, we're doing this internally within AHS and with our partners that are both the Zone Medical Staff Association and PCNs. And so it's working on wellness and setting up a program. There's an organization called WellDoc Alberta that really just focuses on wellness for physicians, and they are can help us to set up a peer support program. So that one is underway. There are some other initiatives. One of them that Colin and myself have been working on, where we're actually going to, it's beyond what AHS normally will provide to support teams, but we think it's a really good idea. And so we're actually going to the foundation with that, saying, let's help to get our teams back in teams, including physicians, back into a better place. And so that's one of the areas where we might reach out externally. So not all of these are the ideas that we've come up with so far. Some would work, some we might find not as successful. Some will work right away, and some are going to take some time to implement, and they have varying degrees of help that we need with them. But with that, we'll kind of wrap up our presentation. We really thank you for the time today. And then what we would like to do is answer any questions that you've got and talk a little bit more about how we can work together. So if we can go to the last slide.
So we're there. We're at the last slide, where we ask the questions.
Yeah, sorry.
Okay.
I
I was waiting for a final ask the questions. Okay, no, thank you. Thank you very much for your presentation here, and I know there's a lot to unpack here with members of council here. Let me open it up to questions that. Okay, so. I'll open it up, and I understand, Mayor Higgin, you have a question?
Thank you, Mr. Chair, and thank you very much for that presentation. Truly appreciate you all coming together and bringing this forward to the Standing Policy Committee. So thank you very much. A question I have is I found quite intriguing was the conversation about the 10 to 15% of those roughly, I guess is what you thought it looked like, that use the emergency department for their primary care. Is that correct?
Yeah, we think, and we think we can do a better job of tracking that as we get our dashboard up and running. But when we take a rough look at it, we guess at, okay, from a sampling of a number of days, it looks like about 10 to 15% of the patients are unattached.
Now, another question I have in talking to an acquaintance here about some of the medications that are prescribed that need to be done through a family physician, is my understanding. And maybe you can explain this to me, that when they go to the emergency room, some highly addictive medications that are non-refillable, et cetera, and that they need to see a family physician, which maybe they don't have one. Currently, what is being done to help, go through this process where those individuals need this medication, and they need it within a day type thing sometimes?
I'll let you start, Tulani, and then I've got a little bit to add too. So go ahead.
Sounds good. We were able to find some physicians who were very kind to agree to prescribe opioids for our patients. They are based in Calgary, and they prescribe virtually in clinics that are already established here in Lethbridge. So when those patients present to Emerge, Emerge has the fax number to that clinic already. So they just get redirected to that particular clinic. And the emergency physicians are often willing to prescribe for at least a day or two until the patient is able to get into the clinic for their opioids.
And if there's no clinic, though, that's my question. So they would still need to find a clinic to attend to, or would this be virtual as well?
It's virtual.
Yeah,
Okay. It's available all the time to them.
Thank you.
Yes.
And then I'll just add, because Colin and I have had some conversations with the leads for the Alberta Pain Strategy, which is run through the strategic clinical networks for Alberta Health Services, and they're going to be working with us closely because there are times, again, really we need enough family doctors, but to bridge those kind of situations, sometimes for short term, you can collaborate with pharmacists as well. And so they've got kind of a model that's set up for it still to be safe, but not as dependent on having physicians. So we're kind of early into that work, but we think that's going to be part of our interim bridging sort of solution as well, as to look at some of those strategies.
Thank you very much. And if I could, one more, Mr. Chair, and then I'll hop out. Is that okay?
Yep.
Okay. Also now, and I think you kind of talked a little bit to this or alluded to it, that the cost to seek care in an emergency room is far greater than, of course, being in a clinic. And so is this another large reason to be able to, not just the time to see a physician, but the cost that is incurred is using the emergency room as a, I guess your local clinic, I guess, for some people because of the lack of physicians in the area.
We've done a little bit of work on looking at that now. We know clearly the physician costs are higher. Just if you look at the billings to Alberta Health, it's going to cost them more money to have that same patient seen in an emergency department as compared to in a clinic. And I think you're absolutely right. I mean, an emergency department is going to be much higher cost care as well in comparison to that same person visiting one of the clinics in the community. A little more challenging to come up with the numbers on that to make sure we're comparing the right things to each other. But yeah, it's pretty clear that it's more expensive care, what we're doing right now.
And a lot of times specialized services there as well, right? The emergency room specialists or other specialists that are doing that care.
Yeah. And also also for the patient, it's not the ideal environment, and it doesn't connect them to the continuity of care that a medical home can provide.
Excellent. Thank you very much for that.
Councillor Carlson.
Thank you, Mr. Chair. Folks, thank you all for coming today, because it is quite a topic of discussion in our community. Even though council isn't the direct controller, I guess we'll say, we do hear the concerns of our residents, and we appreciate you folks going forward with some of the information. And I especially love the solutions and the innovations that you're talking about, because they were many of the ones I wanted to bring up. The virtual care especially, I thought is important. Are there any others? Well, first I'll go, any other solutions? What are they called? Pharmacist practitioners, I believe is the term. At least that's what I've heard it called. And I've heard that is something that can help alleviate some of the pressures. But I also heard that we have very few. I think Dr. Mitsali had an answer.
You're quite correct. I think what you might be referring to are nurse practitioners. And we have examined that option many a times. And we think that nurse practitioners would come in very handy in resolving this problem. Unfortunately, we're unable to do it just yet because nurse practitioners do not bill fee for service. They are employed by, they are salaried individuals. So it's hard now to install them into clinics, but in the future, as we attempt to build an academic clinic, we certainly will have nurse practitioners on board.
Thank you. Can I just follow up and thank you? I see Schultz has. Are you all doctors? Can I call you all doctor? Is that?
I'm not a doctor.
I'm not either.
Oh, all right. I'm just. All right. So, then forgive me if I miss the honorifics completely. I guess further to that, is there anything? Mr. Mitsali, Dr. Mitsali, that council can do advocacy-wise. You say nurse practitioners aren't allowed to direct bill. Is that because of legislation, or what is that something we can advocate for to the province or the feds or whoever controls such things?
Okay, I'll let Andrea answer that question. Thank you, Andrea.
Thanks. So I just wanted to comment that Alberta Health has actually provided separate grant funding for nurse practitioners to work directly in family practice clinics. So we recently applied and received approval for 4.6 FTEs to work in our participating clinics. So a couple issues with that. So first of all, there's the recruitment of those positions. There's not an abundance of them that are waiting to work in primary care clinics. And the second piece around that is primary care clinics would also have to give up space that family physicians are using while they contribute to overhead to run that family practice model. So there's a couple challenges with that.
Okay, thank you for that. It kind of leads to my second question, which was about, we talked a lot about the doctor shortage. A doctor doesn't operate, so to speak, in a silo. Are there other shortages that we should be talking about, like LPNs, RNs, or whatever the case may be? If we recruit 100 new doctors, have we solved the problem because we don't have the support staff around them? So I'm wondering if that's being discussed as well.
Yeah, I can. Hi, Jeff.
Sorry.
We do have a shortage of nurse practitioners, just to add to the previous comment. So that's part of the challenges. We do have grant funding, and we do have positions open for nurse practitioners. It's just there's still some individuals working through their training right now, but we do have some challenges with LPNs. But we are working closely with our academic institutions just to make sure that they can work with us on supplying those staff.
Okay, thank you for that. Mr. Chair, I've got another page of questions, but I'll hop out to give other folks a chance. I just need to check something. Councillor Croson had joined us, but she had some internet connections, so she had sent me some questions on her behalf. But I still see her on my screen. Belinda, can you connect, or shall I hop in to ask some of your questions? Sorry, Mr. Chair. I'm not hearing from. Oh.
If you wouldn't mind asking them, because Wi-Fi is weird where I'm at. Thank you.
Okay, I'll hop out and hop back in with yours. Thank you.
Thank you. There are other in the queue here. Councillor Palladino.
Thank you, Mr. Chairman, and thank you for the presentation. I guess I'm trying to reverse engineer this question a bit here. We know that we don't have enough doctors in Lethbridge, and we know we're not recruiting enough. So what's causing them to leave Lethbridge, I guess, is the question. Not any of us, or all of us that ran for council probably had the doctor shortage on our radar. And so I'm trying to figure out what's causing them to leave. Why is Calgary and Edmonton not facing the same thing?
Maybe I'll start, but would definitely, if the chair's okay with it, look to some of our other experts, because we've all, between the PCN and AHS, and we've taken a close look at this, and best we can tell, it's garden variety reasons that people are leaving. Nothing surprising. They're retiring. They're moving to other places. A fair number of our physicians, because the sponsorship lasts for 5 years, they may choose not to stay after the 5 years. And that's why we do think of this as it's a recruitment and retention problem, because it just happens that many of our newly recruited international graduates, their sponsorship period was up, and they chose to move somewhere else. So we're looking at it as it's more so, I would say, we've never had a problem replacing the doctors who've left, and so why are we not able to find replacements? I have gotten I don't know if this, I guess from a Misery Loves Company point of view, it's okay, but we are learning that around the province, really what provincial leads for primary care are telling us is we're just the tip of the iceberg. We're first up with this. Most communities are going to start to experience this problem. So I guess on the silver lining side of it, we've gotten an earlier start at working on it. I don't know if any of the others had anything to add to that.
I can jump in. It's Susan Byers. I think that Michael's right. It's very multifactorial. So we've had some physicians retire, leave for family reasons. I mean, there's always migration of physicians around. We just haven't had those replacements come in. Some extra stressors that happened in the last couple of years. So the COVID pandemic, of course, which changed some of the practice styles and included more virtual care, which in itself brought on some financial challenges because it's not remunerated as well as in-person care. And just some billing changes in the province really, everything together just really destabilized those primary care clinics and made their business model less effective. And so that on top of regular life changes for physicians has just made it really difficult to get people to come. I think to Alberta in general. I think Lethbridge, Michael's right, Lethbridge is really the tip of the iceberg, and there are a lot of other communities that are struggling as well.
Yeah, if I can just make a quick comment on that to support Susan's statements there. You know, we have for a long time sort of had, as each physician sort of phases out of practice or retires or moves on, we've had somebody slip in to replace because we've been an area that's very attractive to come and set up practice and bring your family and have had lots of advantages that way. But I believe there is a very real sense from physicians in the country that Alberta no longer has the advantage that it used to in terms of setting up practice. And it's made it very difficult to attract people to come to the area as a result of, for example, lack of a master agreement, a bunch of structural changes that were made to billings that are now making it difficult to build a sustainable business practice in primary care. And that's making it very difficult to attract people in. Talani talked about a clinic, sort of a resident sort of teaching clinic, which Lethbridge physicians have been involved for a long time in aggressive teaching and developing the next generation of family practitioners, many of which do tend to stay around after their training is done. And the last 2 years of cycles of training, nobody's stayed. Everybody's moved on to another province or another practice out of the area, which has made it very hard to continue building our robust community here.
Thank you. Maybe just kind of sort of an ethereal sort of thought about each of your journeys as you came to Lethbridge, you know, and I think about a number of over the years that I've talked to university professors who've come to Lethbridge because they were only going to be here for 2 years and they ended up being 30 years. And I just wonder if your personal journeys to Lethbridge kind of reflect that. And I wonder if that's part of a recruitment idea as to, you know, I came here, I wasn't going to be here, and I'm here. I've been here this long. Do you have any thoughts about, you know, the life that you have in Lethbridge as a physician? And anyone can answer. Okay, next question.
I can jump in, but
Sure.
I don't really fit that model because I grew up in Lethbridge and then came back after training.
I'm sorry, you grew up in Lethbridge?
I grew up in Lethbridge.
Oh, okay. So that's why you came back.
That's right.
Yeah, good. Anyone
So
else?
I can make a quick comment on that. So I'm not from Lethbridge and really didn't know a lot about Lethbridge and sort of discovered the community through my training, working at clinics throughout South Alberta. And yeah, there's no doubt that once you recognized the valuable dimensions in this community, it was a very easy decision to stay here. And yeah, I think 100% that should be part of our, you know, our advertising, our promotion of the area is those reasons that you would set roots down and stay. And we're trying to build that into the package that we're, developing with Choose Lethbridge and the chamber to profile that for us, so we can, we can demonstrate that would be a reason to come and to stay and to continue to profile the rich and plentiful reasons for being here.
Anyone else want to add on to that? Or yes,
Yes, that's correct, Garland. I also came here to provide locum coverage for a couple of weeks, and here I am 5 years later. I must say that in the larger cities where I've lived here in Canada, I had not had the privilege of driving to work for 5 minutes. And Lethbridge is regarded as a small city, but it's got about everything that I need and that my family needs. We rarely have to go out of town to acquire our supplies. We have never lived in a city where we can just jump into our vehicle in the morning, an hour later we're in the ski hills, ski every day, and then be back by evening. Every time we've had to go skiing, we've had to go over a weekend to make it worthwhile. So Lethbridge is an amazing place. The cost of living is very low. I've lived in 3 different provinces in Canada, and I can't imagine myself living elsewhere other than in Lethbridge. So that is why we are working so hard to promote Lethbridge as a destination of choice for dogs to come and work here, because we know this is a wonderful place for people to live in, and would like it to be a wonderful place to practice medicine. By the way, when I came here as a physician, I thought I knew everything that was to be known about medicine, and I was very humbled by the learnings that I've had to go through here at the hospital. As a general practitioner, the type of patients that I am privileged to look after are super complex. They are complex even for specialists. The dogs that come and work from Calgary, they aren't able to manage any of these patients, and we feel privileged for that. And I'm sure that a lot of physicians would find that attractive.
well, there's a I Love Lethbridge campaign right there. If you could record that, that's fantastic. I appreciate that, because I think that's what we're trying to sell here. And well, I won't go on because of people are in line. But Mayor Higgin, you have another question.
Yes, thank you, Mr. Chair. And you know what, I have pages and pages of this, but I understand it's very valuable time we have here with you all, and so I can appreciate it. So I'm going to keep them very short here. But thank you very much for those answers so far. A question I have, it goes back to the international doctors that we'd looked at in the long wait, the 6 months to a year, instead of the possibility of a couple weeks, 2 to 3 weeks for a Canadian graduate here. Is there any strategies that we're working on, or that Alberta Health or anyone's working on to mitigate some of this? I don't know if it's just the red tape, the timelines. What is there anything that could be done with that, or is there any strategies currently in place, or is there anything we can do to help?
I'll maybe start with that, and certainly that's what Tulani's been living over the last little while as we've been doing these international recruitments. First off, the college has they've got a pretty clearly defined process. There's 2 assessments. One called, there's a preliminary assessment and then a supervised practice assessment. Each are 3 months, and the preliminary assessment needs to take place in a different place than where you're going to be practicing, and that's just to avoid conflict of interest. So some of the strategies are, if we find applicants who only need the supervised practice assessment, then we want to hire them first because they only need 3 months and they can actually start in Lethbridge. They're just supervised by another physician. However, the majority are looking like they need that preliminary assessment as well. And as long as we essentially, now that, if this is something that if places all across the province are recruiting physicians, then the college has to find more assessors. And one of the things that we're working on with the PCN is to really beef up the numbers of assessors. Our preliminary assessors aren't going to assess Lethbridge physicians. They'll assess somebody who's going to go practice somewhere else. But if we do that, then we shorten the wait time for our own physician to get assessed elsewhere. We've also had some preliminary conversations with Medicine Hat, because they also think they're going to be needing to recruit international graduates. So we may be able to swap and we may be able to shorten that. So the bottom line is the college will always tell us their first job is to protect the public, and we've all asked and they don't deviate from their process very much, but I think there are some ways to streamline it for sure.
Thank you very much for that. And I guess not having doctors is tough to protect the public, I guess, as well. So it's a fine line. So thank you very much for that. And I think Dr.
Can I make one other quick comment on that? And maybe Tulani has something to say as well, but I think it's worth noting that the timeline is pretty fixed, as Michael was sort of saying, with maybe some ways to shave corners a little bit. But the cost is also, a major factor in terms of bringing in IMGs. Probably looking at somewhere upwards of $80,000 for a single IMG based on time put in and practice assessment and cost to bring somebody in and then verify that their skill set is adequate for our Canadian sort of level of training, which is really why AHS has only put out a single sort of supported advertisement for a position that will be partially shared at the hospital and then possibly in the clinic. But that cost also makes it totally prohibitive for clinics to go and seek IMGs. They just cannot possibly fund that kind of money to bring somebody in from out of country, when we can hopefully tap into our Canadian trained resource at very minimal cost, somebody that's already has their licensing in place and can basically just step in and take their spot in the clinic and be up and running.
Thank you.
Okay. In addition to what Garland and Michael has said, we have had about 40 international graduates apply, and they've all been vetted. And the 9 that we are currently interviewing are very advanced into this process. They are something like 3 or 4 months into it. They've been in the province for a year or 2 doing observership, and they've taken their exams and whatnot. So the 4 that we've interviewed so far, we're looking at giving them letters of offer already, and then moving them on to the next step within the next couple of weeks. So that would result in them being able, if they are successful in after taking their exams, they would be ready by August, September to come and work in the city. And then we're going to bring even more candidates than that. And like I said, they are they are in the advanced stages of the process already.
Excellent. Thank you very much. Thank you very much, Mr. Chair. I'll hop out for now.
Councillor Schmidt-Rempel.
Thank you, Mr. Chair, and certainly thank you to all the presenters for taking the time out to do this with us today. There's a mention of working with Choose Lethbridge and the Chamber and putting together that promotional plan for the City of Lethbridge. How far out is that plan for implementation, and where's that at right now?
So I can step in on that one. I've been sort of working most closely with Trevor on trying to reshape a lot of his existing sort of materials since that organization has been involved in lots of business promotion and for the area. So I had a lot of existing materials that he has reshaped to focus on family sort of medical marketing strategy. And I believe it's sort of ready to roll. with some fine tuning. We certainly, some of the promotional materials we could fine tune by having some editing from a committee that's willing to sort of step in and take on that role, which I'm quite happy to be a part of. And then I think the next step would be to target those materials to very specific programs. So residency programs in Canada, which I can easily put together a list of. Many rural communities already do so for attracting and recruiting physicians to their area. There are a couple of key publications like the Canadian Family Physician Journal, which also has lots of advertisements in it, that we could put out there. And then we would need some central location for any interested parties that are seeing those materials and wanting to follow up on them, somewhere that they can then contact, say, this is our contact in town here, that would then guide them on next steps and guide them on, you know, what the community clinics are and who they can go talk to and so on and so forth, and getting their licensing in place. So I feel like that's very close. We just need kind of that next step in some collaboration, potentially with somebody from the city on that.
Yeah, I think that's where we really need some collaboration, because everyone's doing this off the side of their desk, and we have no actual funding for any materials or, you know,
and a home base, yeah, and a home base where then anybody who's wanting to follow through on those materials from somewhere else can then call or contact or email and say, what's my next step? I want to come see the city. I want to do the tour. I want to see all the clinics that are available. That might be places I can work. And I not to put Susan on the spot, but I feel like the primary care already as a central hub of all the connected physicians makes a lot of sense to be, you know, part of that trilogy, I suppose. And then, you know, somebody from the department like myself and somebody from the city, from the community would be, you know, an obvious third portion of that. Yeah, that partnership.
Yeah, I think the PCN would certainly be happy to be a contact and act as a hub. We just really don't have many resources that we can, you know, allocate to the project. That's the problem.
Thank you for that. And then I guess just a follow-up question to that too. Certainly doing the profiles of new doctors. What they like, what they don't like, that's definitely invaluable information to have. What would we need to do to help out with looking at something like turnkey style clinics, advocacy-wise, or even that academic family medical clinic that we're talking about? What on our end can we be doing to sort of look at getting those things set up in our community?
I'm not sure at this point because we don't have any plans in place. But what I think you can do at this time is to be a part of what we're doing. And as we brainstorm and put plans together, be a part of the planning process early on. The other thing that I wanted to mention is that the work that Trevor and Garland have been doing is excellent. It's amazing. It's an amazing marketing strategy, which really is a true reflection of what Lethbridge is. But I do worry that you know, physicians are a market, and all the cities and provinces are competing for the same physicians. So, and I'm not saying we should do this, but I'm just throwing a thought out there that what if we put out tangible incentives for the physicians to come and work with us. In some clinics, in larger cities like Edmonton, for instance, they pay a sign-on bonus of around 100,000. I'm by no means saying that we should be paying that amount of money for physicians to come here, but if we offer them moving costs, for instance, or other, you know, minor incentives, I think that that would go a very, very long way in bringing in Canadian trained physicians who are ready to come and work, and it would certainly be far less than the 80,000 that is currently being paid to bring in IMGs.
Thanks, Tilani. If I can just add, because on the other part of the question about the academic family medicine clinic, we think that's a way to tie together. It's not the whole solution, but really to tie together some of that, exposing new trainees to the community, meeting some of the needs of our more vulnerable patients, and being a little more innovative in our practice. So I thought this might be a good time just to extend an invitation, if that's okay, Tulani, to December 9th. One of the associate deans from University of Calgary School of Medicine is going to be here giving us a presentation, an information session on the academic family medicine clinic. And we're definitely excited about that. And I think it's the kind of thing that PCN, family doctors in the community, AHS, it's beyond us to put that. It would be something we'd have to work together with the whole community on. But if anybody wants to learn more about that, just drop me a line, because I'm happy to extend the invitation to you.
Thank you. Sorry.
Can I just make a comment on the question about turnkey clinic style? I guess I want to emphasize that clinics in town, aren't sort of struggling because of lack of of business savvy necessarily. We have an extremely hardworking group of physicians in this city that run very successful practices, multidisciplinary primary care clinics with large group practices that do very, very well. And I believe that model still is the one that we want to support. It just is hard to run when we've had a number of retirements and not replacements to put those people back into place to allow those businesses to still run. I believe there would be some interest in maybe a role for developing some sort of collaborative clinic. Let's say, we have all kinds of space and building spaces in town that might do better if they were developed properly, or there was an investment from a very reasonable external source. And I don't mean some big corporate entity that just runs clinics all over the world and does it at full profit. This would be more a local entity that's like, we're going to invest in developing this building, and then we'll invite the physicians to come in and work, and they still pool in some of the overhead to keep that clinic running. I feel like there would be benefit and value in some sort of locally run structure that way. And possibly there's some other ways to support how clinics maintain their cost structure in the city. I don't know if that would be in terms of tax incentives or in terms of some other way there. I don't believe there would be a lot of support amongst our primary care physicians in town to bring in some outside turnkey operation. I don't think that's a solution. I think that results in clinics that cut a lot of costs and patient care in order to make profit. And none of the clinics in town currently run on a profit-making structure. They work on cost recovery, and they employ lots of allied health and nursing staff in order to keep their clinic running. But it's a sustainable model. It's not a profit-making model, and I think that's what we'd be looking for to continue building our the robust practices in town. Yeah.
Thank you.
Councillor Carlson.
Thank you, Mr. Chair. Fortunately, through many of the questions and the presentation, you answered most of Deputy Mayor Croson's questions, because if I were to ask them, I'd have to pretend to be much smarter and more informed than I am. But a couple of things. I'm hearing a lot of it's a big, hairy issue. I'll put it that way. Although I'm glad or sad to hear that it's an Alberta-wide problem, it does hearten me to know that it's not Lethbridge focused, that it is Alberta-wide. One of my concerns, though, is that if we do an amazing job of recruiting and retaining folks, we're just poaching from our neighbors. and then they're going to be in the same job, and then we're in a race to the bottom. So we've got to solve it for all of Alberta, not just Lethbridge. So I'm curious about some strategies or some advocacy work we can do, because I don't think this is a problem that council is going to solve, but there are pieces we can attack. I heard discussion around the lack of the master agreement, the changes to the billing process. Are there some tangibles that we could work at? And I don't need to hear them now, but I'd like you to consider those while I ask a question of our city manager. If Craig, I hope you're still around.
Yes.
Ah, thanks, Mr. Dalton. I guess the question to you is I'm looking for your sage and focused advice. Where do we go from here? I have thought about, and Deputy Mayor Croson and I have talked about where do we go from here? Is it a referral to advocacy for the pieces that advocacy could do on our communities, on our doctors' behalf, on the entire province's behalf, so to speak? Is it back to your office, Craig? I know that I think it's Carly has been doing some work, and we've got little pieces that we're doing about marketing and communication in that. I'm just wondering where best council could refer or just make a place for some discussions. I think our guests have made it open that they'd like to work collaboratively together, and there are some opportunities. I just don't know which one to bite off or where to put it to start biting. So Craig, do you have any thoughts? Is it back to your office to sort of delve in of what are the pieces council could attack? Or is it advocacy, or is it a mixture? And sorry to put you on the spot, Craig.
No, not at all. It's a great question, and that's what I've been thinking about for most of the conversation. So I think it is back to my office and continuing the work that Carly's done, working with Dr. Alden. I think it's summarizing what council has heard today and what's left to be said today, and bringing forward a report that I think provides some options for council to consider in terms of what areas they may be able to provide support in. Whether those are advocacy or other areas. And then I think there are some other things that have been mentioned here today, like incentives, like collaborating on marketing work, that I think we need to dig into a little deeper. So I think it is us now taking the information that's been shared, the comments of the committee members, and spending a bit of time thinking through that and coming back to council with a more informed roadmap, perhaps, for council/city involvement.
Thank you, Mr. Dalton. I knew you would have the answer I was looking for of where do we go next, so I appreciate that. Maybe just a final question from me to our guests is, does that seem appropriate? I know you've had some contact with the city manager's office and sort of organizing this and gathering some information. Is there anything else you wanted to share with us today, or is it best to say, continue on? We appreciate hearing this information. We need sort of Craig and his team to take some time to say where they best think council can have an impact. Does that make sense?
I think it's very heartening to hear that. Like we would like to work together. There's not exactly a roadmap to doing that. That's what we learned when AHS and the family doctors and the PCN were coming together. So I think in whatever form that looks like for the city, if we can join up with you in some way, and I'm sure the rest of the team are behind this as well, is 100% agree with, let's come up with some tangibles, and that's really how we've gotten as far as we have so far, is what's the next thing that it's not going to solve the whole problem, but the next step that makes sense for us all to do. And I think, yeah, working together on some advocacy and some connecting the dots on some of those strategies would be perfect.
Thank you.
And for myself, representing the community family physicians, I agree. I think we would be very appreciative of some partnership and in helping promote, continued best, family practice for sure, and best medical care for our community. And our avenue really to date has been through the Alberta Medical Association, our provincial advocacy body, and then really spending as much time as we can having discussions with Mr. Newdorf, our MLA, and coming up in a little while here, there's been a handful of individuals invited to a roundtable meeting with our new Minister of Health to try and identify some avenues for better professional dialogue. So having the city involved in that as best they can would be greatly appreciated. Yeah.
Thank you.
I just also wanted to thank council in the city of Lethbridge for the work on housing and working with vulnerable individuals in Lethbridge. And that also has a part to play. That's a connection point for our health teams and physicians. And that's an opportunity for new physicians coming in to do some work with some of our most vulnerable individuals in Lethbridge. So I just wanted to thank the city for their leadership on that front as well. Thanks.
Thanks, Colin. Appreciate hearing that. So, Mr. Chair, that's it for me. But if I can just finally to Mr. Dalton, City Manager, do you need a referral from this committee to continue the work, or I know that your office is already doing that? Would you like something more formal?
I think Mr. Westerson is making up a thing.
Crafting a resolution?
A resolution. Those are, yes, I'm still learning the words that work at council. Just back to our doctors, is there another group that should be included in the Rolodex? There's a word. In the, in terms of going forward, is there another group that should be included in all of our discussions that the city manager can take with him as well? Or have we got kind of the working model right now?
The only other one that comes to mind that came up in our discussions was would be Dr. Elaine Godwin and maybe a representative from the U of C, who are the primary ones working on this teaching clinic idea to try and bring more resident and physician teaching into town, and hopefully through that leading to some further individuals that stay here. So that would be the only one in the group that I feel like would be an extra addition that would be valuable.
Okay. That can be duly noted. Are there any other questions with members of the standing committee, or any other concerns or anything else from our panel? Okay, that's gentlemen, I really and ladies, I really appreciate this. Is I'm sure we could go on for another couple of hours because it's really is a big part of our community right now. So I really thank you for taking the time out, for coming to us and giving us a lot of information that we'll digest and try to figure out where to go from here. So thank you. And I do have a resolution that I'll ask from Councillor Carlson. Be it resolved that the Cultural and Social Standing Policy Committee refer this item to the City Manager to continue developing an action plan to be brought back to City Council. Does that work for you, Councillor Carlson?
It works for me. I want to ensure it works for Mr. Dalton. I don't want to put words.
He got the he's the one that kind of co-wrote it. No, he didn't.
Excellent.
Okay.
Well done.
All right.
Thank you. And again, I'll just open by saying I appreciate you coming to this committee, and I appreciate Mr. Dalton's office working with you to bring more information back to council, because we know it is a big, hairy issue, and it's not something that anyone owns all of. We can all maybe have a piece of. So hopefully we can build a roadmap or an action plan, I think, as the resolution says, and we appreciate that coming forward. So with that, unless there's anything further, I'll call for the vote.
All in favor? All right, that's unanimous. Thank you, people. Thank you, everyone. That was great.
Thank you so much. Thank you so much. Yeah.
Thank you very much for the time today. Really appreciate it. Bye-bye.
Thank you.
Thank you. Okay, and we're out of time. Thanks, everyone. Good night. We'll move to 5.2, Ross Kilgore, Community Planner, regarding the Heritage Management Plan Update Project. Mr. Kilgore.
Okay, good afternoon. Thank you for taking my presentation today, members of SPC. I understand we're quite limited for time, so I'll try to keep it brief and then be delighted to take your questions. So I'll give you a quick bit of background on what the Heritage Management Plan is, why we're undertaking this work to update it, and then the status of the project today. So next slide, please. So our current Heritage Management Plan was actually the first Heritage Management Plan that the city has had. It was adopted in 2007. If you read it today, it does read as quite out of date. It reads as a number of recommendations of how we could set up our heritage program, which obviously we have done since then, and it's actually evolved quite a bit as well over the last 14 years. One big kind of headline takeaway item is that it does not include Indigenous heritage at all. It doesn't make mention of the word Indigenous or Blackfoot or Métis, which obviously seen from today's lens, where we've made quite a bit of progress in recent years in Truth and Reconciliation, is quite jarring. Next slide, please. Since the Heritage Programme was set up, there has been some evolution of the programme over the years as well. Heritage Advisory Committee became Historic Places Advisory Committee, which is the standing committee of council that advises council on heritage matters. The membership of that committee was expanded a few years ago from 3 to 5 members, adding an Indigenous rep as well as a traditional land use expert. And they've been instrumental in some of this work and starting to expand the scope of our heritage programme. Next slide, please. So why update the Heritage Management Plan? Well, really the basis for this in terms of policy is in our Reconciliation Implementation Plan, which in 2017 set out these recommendations you can see on this slide. So really it's all about figuring out what our protocols and guiding principles should be around working with Indigenous heritage sites. Obviously there's a lot to unpack there that we maybe don't have time to get into here, but it can be quite different certainly from what our heritage program tends to have dealt with up to now, which is usually or almost always individual properties, buildings, houses, so on. If you're dealing with an Indigenous heritage site, which may be completely exposed in the river valley, it's certainly a lot more vulnerable in terms of being open to vandalism or even theft. So how do we figure out how we're going to protect these sites, celebrate them, and ensure that we're not getting in the way of their continued use as well, because of course some sites have been in continued use for thousands of years. Next slide, please. And then further, also in 2017, the TKUA, or Traditional Knowledge and Use Assessment, was completed. That was a joint project between the city and the Blackfoot Confederacy Nations. It was an award-winning study, and it made several recommendations again around Indigenous heritage sites within the city. Next slide, please. And then finally, all those recommendations were pulled together and put into the form of policy in our new MDP. There's 2 policies in particular which address this work and direct us to update the HMP. Next slide, please. And so really the objectives of the project are, as I mentioned, to work directly with the nations and the Métis Council and our urban Indigenous peoples to update our HMP to include Indigenous heritage, but then also to take this opportunity to look at other options in terms of perhaps working with heritage districts or areas, to also look at other underrepresented stories in our city's heritage, because obviously for various reasons, a lot of our heritage to date has focused on white, rich men from our city's past. So we're looking at other opportunities to celebrate different aspects of the city's heritage too. And then finally, just from a more administrative point of view, to ensure that our heritage management plan actually reflects how our heritage program works today. Next slide, please. So in terms of roles, I'm the project manager, but working very closely with Perry Stein, our Indigenous Relations Advisor, who's certainly been a critical part of managing this project as well. We have set up a working group to help guide the project at key pieces of or decision points throughout the project. So that's composed of Perry and myself, as well as 2 members of HPAC and a member of RLAC as well. We've been working in recent months with 2 consultants. I've called them Consultant 1 and 2 here just for brevity. The Consultant 1, No History, we've actually concluded work with them now. They conducted a best practice review for us on certain aspects of our heritage program. And then the Consultant 2, which is a team composed of the nation's consultation departments, as well as Seed Heritage and Arrow Archaeology. we are currently still working with them, so I'll give you a bit of an update on that in the next slide. And then in terms of funding for the project, it comes majority from Planning Design's operating budget, partially from HPAC's budget as well, and then we did win a provincial matching research grant as well. Next slide, please. So this is where we're up to. I last spoke to this SPC in February on this project. Since then, we've made significant progress, as you can see, and a bit of an update since this presentation was submitted is that next step there with the communications and engagement plan with Consultant 2. They've submitted that draft plan to us now, so we'll be meeting with the working group in the coming weeks to finalise that. That will then allow us to move on to planning the actual collaboration sessions with the different Indigenous groups early next year. The way that the project is set up due to the size of the budget is we're not having a consultant actually write the plan. I'll be doing that. So once I receive back all of the reports and recommendations from the consultants, I'll start work on drafting the plan. The first draft of that will then go back to Consultant 2 just to check in and make sure that actually captures what they heard during the collaboration sessions. It'll go through legal review as well. Then we'll take it out to a wider public engagement for their input. And then a final draft will come back to City Council. And then I'll just point out as well in that final row there it states that would come back as a bylaw for first reading. In subsequent discussions with City Solicitor's Office, we feel that it's actually more likely that it will be policy-like, so it'll probably come back for Council's approval and adoption rather than as a bylaw for 3 readings. Next slide, please. And so that concludes my presentation. Be happy to take questions.
Thank you, Mr. Gilmore, for the information. Great work. Do I have any questions from the Standing Committee? I see none. You did everything that you could have done. Thank you very much. Appreciate it. Since there are no other questions, I have
Sorry, Mr. Chair.
Oh, yeah.
Sorry, I buzzed in, but I'm maybe having difficulties here. Just a quick question.
Yep, sure.
Thanks, Ross, Mr. Kilgore, for the presentation and the update. And you may have had it in the slides where I just missed it. The participation from this committee and from council, where does that occur?
Thank you, Councillor. Great question. So yes, we would come back to this this committee with the first draft of the HMP. That's the current plan. Certainly happy to change that if you would like it done at a different stage.
I guess I'll just ask my colleagues at some points, council or the committee that's overseeing it has asked to be a bit more engaged to sort of know where things are going or to be actually considered as one of the stakeholders in the discussion. I'm just wondering if we want to just get updates or is there room for any involvement from members of council or the committee?
For me, I like getting updates. That's my thought. Anyone else?
Yeah, I would be on the side of updates as well. It does look like there's plenty of time for us to engage too as the drafts come to us and offer feedback there as well.
Okay.
Thank you.
Any other questions?
Just finally to Mr. Kilgore, is that appropriate or would you like more participation from members of the committee or do you think that the stakeholders and the folks you're working with are the actual ones that need to be involved and council is just sort of along for the ride?
Certainly, I think at this stage of the project, it would be the latter, but certainly once we've heard from those Indigenous groups and started to try and put their recommendations into a plan form, I think that would be a great point to have this committee's input and see if you kind of agree with those findings and recommendations.
Perfect. Thank you. Thank you, Mr. Chair.
Thank you. Thank you, Mr. Kilgore. No other questions. I now have a resolution from Jen Schmidt-Rempel. Be it resolved that the Cultural and Social Standing Policy Committee received the report regarding the Heritage Management Plan update for information. Jen.
Yes, thank you very much for that. Well done. When I read through it over the weekend, everything looks like it's there, and certainly it's time to review this plan. So I appreciate the work that's going into this. I appreciate the stakeholders that have been pulled in, and I'm really looking forward to how this moves forward. I'll call the question.
Question's been called. All in favor? Anyone opposed? I think that's unanimous. Thank you very much. On the agenda next, we have 5.3, Jillian Bracken, Community Arts and Cultural Manager, a placemaking introduction and overview of projects. Jillian.
Through the chair, thank you very much. I'm just going to do a short introduction to the placemaking. So, afternoon, Mayor and Council. I believe placemaking is a vital part in every community. It makes people feel welcome and gives them a sense of what our community is about. There has been a cross-departmental team working to create a process to move placemaking forward. And Jillian has been part of this team and will be providing an overview of placemaking and some of the projects that are underway. And with that, I just want to pass it over to Jillian.
Thank you. Okay, and good afternoon, Chair Campbell and members of the Cultural and Social Standing Policy Committee. Placemaking is the collaborative process of creating quality places where people want to live, work, play, learn, and build community together. Placemaking is both a conceptual approach and an actionable tool to create, activate, and reimagine public spaces. It infuses culture into spaces, facilitating ongoing creative community connection and utilization. Next slide, please. Placemaking as an intentional process results in the creation of great shared spaces. And what makes a great space? All of the things you see outlined on this image from the Project for Public Spaces. Key attributes like sociability, broad usage and engagement and access, intangible characteristics rooted in lived experience, embodied by words like active, vital, walkable, connected, and welcoming. Next slide, please. Today's presentation and accompanying report introduce Council's Cultural and Social Standing Policy Committee to the concept of placemaking, examining it through the lenses of planning and land management, economic development, cultural and social development, and reconciliation and inclusion. The accompanying report offers updates on several in-progress and anticipated placemaking projects, including the Heritage Management Plan, which we just heard from, the Civic Culture Plan, the Public Artwork Plan, the Indigenous Placemaking Strategy and Public Realm Audit, the Indigenous Legacy Commemoration Project, the Monument Policy Review, and the creation of a placemaking implementation framework. Placemaking is not a new idea. It is rooted in the work of Jane Jacobs and William H. White in the 1960s. It's also not a new concept for the City of Lethbridge. A lot of informal placemaking on different scales in a variety of departments has taken place for many years. So why should we now be thoughtfully considering this concept as a corporation and as a community? Next slide, please. The concept of placemaking received significant attention in the city's recently updated Municipal Development Plan, the MDP, with the concept contributing to 2 MDP outcomes: a culturally vibrant city and a well-designed city. The MDP defines the term as including, quote, the planning, design, management, and programming of shared use spaces to help define a community's cultural, economic, social, and ecological identity. Placemaking contributes to, while also drawing inspiration from, sense of place, end quote. The MDP recognizes how public spaces, when both well-loved and highly utilized, can generate a wide range of benefits for the community. While placemaking has in the past been informally incorporated into city projects, the successful application of the concept and its newly elevated importance in the MDP suggests that there is a need to think more strategically about implementation. We need to be more intentional in how we work with the community to build and activate public spaces. Placemaking, when successfully applied, will facilitate growth across many domains examined in the MDP, including, and I'll just get you to click through these last few slides, planning and land management, economic development, cultural and social development, keep going, and reconciliation and inclusion. And just to the last slide. A cross-disciplinary working group, just to the next one, led by public art, urban revitalization, planning and design, and Indigenous relations, will work collaboratively with other related city departments to develop and recommend to Council a streamlined placemaking implementation framework for the City of Lethbridge. And I'm joined today in person and virtually by colleagues in these areas, all available to answer any questions you may have about their respective placemaking projects. Placemaking creates a forum for collaborative, cross-disciplinary conversations that put the community at the center of planning and project execution. Placemaking starts with an outcome in mind, a desire to create a functioning and vibrant place, and this outcome guides all decisions made along the way. It can help ensure the diversity of our community is reflected in the design of public spaces and help leverage city investments and community partnerships to generate the greatest possible impacts, both direct and tangible and indirect and intangible. The development of a placemaking implementation framework will require bold, visionary leadership and action at all levels of the organization. If thoughtfully and purposefully crafted, this framework will serve as a platform for cross-departmental conversations at the City of Lethbridge. It will also serve as a gateway for the public to be more meaningfully engaged in planning and activating shared public spaces. Today's introductory overview is offered as information. Administration looks forward to continuing a placemaking dialogue with Council by way of future project updates and presentations. Thank you.
Thank you, Ms. Bracken, for the update. Do I have questions from members of the Standing Committee? Councillor Carlson.
Sorry, Mr. Chair, I'm chatty today. Ms. Bracken, thank you for the presentation. I think it's Mr. Malcolm and Mr. Stein who are with you, as well as some others I may have missed not being there in person. I really appreciate that we're now thinking of taking a more thoughtful and purposeful approach to placemaking in our community, for our community. Can you maybe give me any examples in our community currently where we've either really succeeded, even without a thoughtful and purposeful approach, or terribly failed and sort of done the scatter dash, just to sort of highlight for folks exactly what we're talking about and how you can succeed and how you can fail?
Absolutely. Thank you, Councillor Carlson, for the question. I think I'll turn this one over to my colleagues first, since you've heard me doing so much talking. I'd like to invite Andrew up to the microphone to maybe explain some of the placemaking projects that he's completed as part of his portfolio. And then if Perry's available as well, I'd ask him to comment, and Ross as well.
Thanks, Jillian. So I won't speak on a whole bunch of projects, but I think one that is particularly interesting for Council is the 3rd Avenue reconstruction project between 4th and 8th Street in their downtown core. If we were looking at this just simply as an infrastructure replacement project, knowing that we replaced all the underground infrastructure, we would have ended up with a 4-lane road back in its place, looking much like what was there before construction started in 2019. By putting a placemaking lens and bringing in a multidisciplinary group to look at that project, we ended up with a flexible parking area that functioned as a patio parklet area this summer. If you were down on that strip throughout the summer, obviously fueled a little bit by the pandemic and the conditions around outdoor eating, but the feel and the vibe on 3rd Avenue was completely different than in past years. We had full patios, people sitting out, a much safer and vibrant community than what we've ever experienced on 3rd Avenue. Layering in collaborative approaches with public art, we took the rail out of the ground and have collaborated with Allied Arts Council to bring in a structural or a sculpturist to turn that rail into an art piece, which will sit along the 3rd Avenue corridor to reflect on the history of the area, but also be a draw into the community. In addition to this, with grants and incentives, we have stimulated a lot of economic growth, the Owl Acoustic Bar being a perfect example. They have reinvested private dollars into the area to build and to program and to create vibrancy on this strip. So those are a couple examples of how one project like the 3rd Avenue reconstruction has taken an informal, in this instance, placemaking approach to deliver a really strong outcome, and it's not even quite complete yet. We saw some sneak peeks of it over the past summer. But I think going forward, that would be the approach that we would look to deploy in a multitude of different projects going forward through this kind of more thoughtful and purposeful approach to placemaking.
If I could just add just a small comment in there, I think it's the work that Andrew highlights is amazing work, but it's also important to highlight that this doesn't always cost a lot of money. The work that we did this summer with our partnership with TELUS to activate the underutilized space on the outside of their building, the work of the Oki sign that's behind me in the last couple of years, and even the mural at the new fire hall, combined with the Indigenous walk along Great Bear Boulevard that will soon be activating our community, are examples of relatively smaller, much smaller investments, the leveraging of partnerships to move placemaking forward. So it happens at all scales. It happens with partnerships. It happens with creative imagining of what possibilities are, and then we have to find interesting ways of bringing vibrancy to those spaces after they're designed.
Thanks. I would echo the comments about the success of 3rd Avenue. I'm always shocked when people say to me, oh, we don't go downtown. Oh, it's not viable. Oh, it's not. I was downtown last weekend. We went to see a theater production. Then we started walking around. We couldn't get into the Owl, couldn't get into the Telegraph, couldn't get into Hudson's, couldn't get into the art. Everything was packed. So it is a success. I'm just curious, nobody wanted to broach any failures. And you don't want to shame anyone or any corporation or any era. But are there any things you can point to say, yeah, that's one where we probably should have been much more intentional, thoughtful?
I'll take a stab at that.
Excellent.
And I think this is part of the idea of piloting things and being okay to make mistakes. And like the Oki sign was a super successful project for the lifespan that it had. But I think Andrew and I have learned a lot along the way around how to design something like that, whether it's materiality or size or transportability. So the idea of trying something out, seeing how it works with a relatively small investment, learning along the way, but not being afraid of just trying something with the support of the committees that we both work with, has been an amazing opportunity. So it's not a negative thing. I like to frame it as a positive thing, but we learned a great deal through that and are looking forward to Oki Sign 2.0.
Excellent. Me as well. Thank you for that. Thank you, Mr. Chair.
Mr. Kilgore, did you have something else you wanted to add since you were standing there? I thought I'd give you the chance.
Thank you, Councillor. I was just going to add from a planning design point of view, in terms of placemaking, obviously we were involved in creating the new MDP, which contains a couple of specific policies on placemaking and directs us to do some of this work. As well, under planning and design, we manage the heritage program, as we were talking about earlier, and certainly there's a great deal of potential there for placemaking projects, especially as we get into some of these new areas we're now working on with the heritage management plan. But more generally, I think it's really interesting when you look at a map of any location in the city and think about placemaking. It really crosses over so many different silos within the city. Planning and design tend to deal mostly with private property, of course, and then once you get into the public right-of-way, you're dealing with transportation, maybe parks in terms of street trees and so on. And so I think there's been a lot of progress as well in the last couple of years in just working across departments to achieve an outcome that really doesn't belong to any one team.
Just while you're there, I'm just thinking in terms of placemaking. Just let me understand. I'm thinking of all of the empty buildings that there's some around the city. Is placemaking involved in that sort of what can we do with that space? Is that what placemaking also encompasses?
Placemaking, yeah, it tends to be in the public realm, but it can certainly be influenced by what the adjacent land uses are as well, whether that's in the downtown or commercial type of area, or even a park. Yeah.
Mr. Malcolm, I think looks like he's creeping behind you.
Not to be too creepy there, but I just wanted to add that in the last CIP cycle, there was an approval for just over $2 million for public realm enhancements. And that was framed as an opportunity to partner with private investment to improve areas around the private investment taking place. So in the last 3 years, we have partnered with the Post redevelopment. We partnered with them on the sidewalk enhancement, street light replacement, their new ramp access to their front door, and a public art piece that will be going in, just being commissioned right now. So we are looking to do that going forward when there's large-scale private redevelopment going, that the city has some capital funding available to partner so that the public realm is contributing to the private investment and vice versa. So that's an approach that is fairly new, but we believe we have success with the Post redevelopment, and we're looking to replicate that on other large-scale projects.
And what about green spaces that we have, or brown spaces that there's nothing on them at the moment?
I'd say that they're open for opportunity. When we talk about placemaking, that's not limited to retrofit or redevelopment. If you think about the work that has gone on from our former land department, Opportunity Lethbridge, and places like the Crossings with the large-scale playground development, as well as even like the 2 high schools and the ATV site. All of that incorporates certain aspects of placemaking, and I think we can learn from the informal practices we did when we built those, but and take it a step further going forward.
Great. Councillor Schmidt-Rempel.
Thank you very much, Mr. Chair, and thank you very much to everybody for the presentation. Some time ago, when I was on Economic Development Lethbridge, we did some place brand research as part of community brand development. Were we able to make use of some of that research and incorporate that into this placemaking strategy, since that was part of what we were tasked to do as EDL?
At this point, the development of the implementation framework hasn't yet started. We anticipate being able to start that in probably the second quarter of next year. So that's definitely something that I think we can have some conversations about. Andrew, I don't know if you have any comments on that. I know Opportunity Lethbridge works with Economic Development Lethbridge. If not, we can just identify it as something that we can absolutely look at when we start developing that framework.
Thank you.
Councillor Palladino.
Good afternoon, and thank you for the presentation. This question's for Mr. Malcolm. Just curious, Andrew, the Post project, I really like what happened on that site, and maybe you can throw me a number or two. The city received no taxes on that property until it was redeveloped, because it was a federal building, right?
That is correct.
So the redevelopment now brings in tax dollars because it's no longer a federal, I mean, there's probably a portion of it in there, but can you tell me how much that is, or roughly?
As the project's not complete, I don't have the numbers in front of me, but I know that the assessment of the building, just from the transition from the federal to private ownership, was in the range of $12 million. And then with their improvements that have been facilitated by both the city's incentives and grants, as well as that public realm enhancement, we are anticipating the final assessment value of that property at completion to be around the $18 million mark. So effectively, in 3 years, we've taken a property from $0 of assessment for the city to $18 million. Understanding that's a unique situation where obviously federal ownership had a part to play, but we do see that all of these pieces coming together, really building a really strong economic argument.
Councillor Carlson.
Thank you. Thank you, Mr. Chair. I believe at the end, Ms. Bracken, you talked about the end product. It will be a placemaking framework. Did I remember that correctly, first and foremost?
Yes.
Can you tell me exactly what a framework is? Is it to use a word that Chair Campbell used earlier, is it more ethereal, or will there actually be some deliverables? I'm thinking ahead to our next capital budget. Will there be some thoughts and ideas of where to invest?
So we anticipate the implementation framework will include both deliverables that would set out a kind of philosophical framework or policy that then could guide activities, but then also specific projects. Within the report, I've identified just at the end there are kind of short-term and long-term goals for that development of that framework. So you can see some of the priorities laid out there. One of them is to work within currently approved CIP projects to identify placemaking opportunities as a short-term priority. And then long-term is to embed or share the placemaking philosophy across the corporation, so that these kinds of collaborative conversations are happening before we even come to the CIP with ideas, so that administration and the community are talking right at the beginning about how we can take a placemaking approach when it comes to identifying and developing projects. I see Perry has popped in. I don't know if, Perry, you have something you want to add to that as well?
I was just going to echo exactly what you had already said, Jillian, which is like the future review of CIP projects, trying to create those alignments ahead of time.
And sorry. I was going to say, nope. Councillor Carlson, if you'd like to, we can return to the Cultural and Social SPC when we are ready to begin developing that framework, to give you a little bit more of an idea of kind of timeline and what those deliverables would look like. At this point, we're just kind of continuing on the informal placemaking projects, and then we'll start that actual framework development in Q2 of 2022.
Thank you for that. I think I won't speak on behalf of the committee, but I'd appreciate further updates. Because you talked about future CIP projects and how they could be utilized to be part of this placemaking strategy. Pardon me for 1 second. And I'm just curious, there are other areas of the public realm, they do touch on the private realm as well, that probably don't have CIP initiatives forthcoming. And they kind of look like low-hanging fruit. I sort of think just of the exit or the entryway to City Hall, between the City Hall, the Yates, the county building. It is getting more and more use as a public gathering space. And that's one that I'd love to see considered in this, because it's already being utilized, and I'd love to see it strengthened, enhanced with this sort of idea. So that's only my personal thought, and so thank you.
Thank you. And Andrew, I don't know if you want to comment on that as part of maybe the Civic Common master planning process that'll happen, if that might be addressed.
I can just quickly add that Fourth Avenue corridor was addressed in the Civic Common Master Plan as a more functional public space for things like Remembrance Day assemblies and those types of things. And so we, again, in this last capital improvement plan, we were funded to take the Civic Common to the next step, a comprehensive site plan. And so as we go through that site planning exercise, that will absolutely be one of the projects that we will be implementing this placemaking lens on. And then I think an outcome of that document will likely be probably more tangible capital investments of a scale that I can't comment to right now.
Excellent. Thank you. Appreciate that. Thank you, Mr. Chair.
Any other questions? I see none. Okay. I would be. I know I can speak. This is from Councillor Jennifer Schmidt-Rempel. Be it resolved that the Cultural and Social Standing Policy Committee recommend that City Council receive the report regarding the placemaking, introduction, and overview of projects as information. Councillor Schmidt-Rempel.
Thank you very much, Mr. Chair, and thank you everybody for their presentations today. I know I'm really looking forward to seeing how this moves forward. So if nobody else has any other questions or comments, I'll call the question.
Question's been called. All in favor? Opposed? That carries. Moving along to 5.4, Perry Stein, Indigenous Relations Advisor on the Indigenous Cultural Center Governance and Operations Planning Update. Mr. Stein.
Thank you, Chair Campbell. Whoever's running the PowerPoint presentation, I'm going to jump around just a little bit to be mindful of my 5 minutes of time. So I'll start on the first slide, please. So the purpose of this presentation is to provide SPC members and the public with an update on the status of the Indigenous Cultural Center Governance and Operations Planning Project, including a very brief overview of the work to date, the scope of work in this current phase of work, and some of the upcoming project milestones. If we could go to the fourth slide, please. Perfect. Thank you. So the city's involvement in this project formally began in the 2018 to 2027 CIP with council's approval of funds to conduct a feasibility study. However, it's important to note that the idea of a Blackfoot or an Indigenous cultural center concept has been around for quite some time in our community and has been advanced by different community partners, including the Secoketoki Friendship Society. In 2019, the city's Indigenous Relations Office led the first scope of work with the support of the Reconciliation Lethbridge Advisory Committee and our consultants, Manask Isaac, who are now called Reimagine Architects. The final presentation of that feasibility study was accepted as information by City Council in February of 2020. The ICC feasibility study relied on probably the most extensive Indigenous community engagement effort undertaken by a city project to date. With the funds remaining from the budget of that project, an additional small scope of work around governance was also completed in 2020 and involved the participation of Indigenous and non-Indigenous community partners such as the Kainai, Piikani, and Siksika First Nations, the Métis Local Council, the University of Lethbridge, Lethbridge College, Red Crow Community College, Opagosan, Reconciliation Lethbridge, and the Secoketoki Friendship Society. Background information on both the feasibility study and the governance guide can be found in your briefing package and the accompanying presentation, and has been available to the public through both the Get Involved site and the lethbridge.ca websites since information was presented to council nearly 2 years ago. If I could jump to slide 30, please. It's the one with there we go. That one right there, perfect, thank you very much. So the next stages of work on this project was approved by council in the current CIP, with additional grant funding being provided through the Canada Cultural Spaces Fund in the Government of Canada. And there are a number of individual scopes of work or projects identified in the CIP project. And in the past several weeks, we've begun working on the first. The goal of this project is to re-engage our partner organizations. These are the organizations who have expressed the greatest level of interest in being involved in this project to date. Those are those 10 organizations that I just recently read through, and those are the ones whose logos you can see on the screen. Once engaging with our partners once again, we seek to validate and operationalize a proposed interim governance model, and that information on that governance model is in this presentation on slides 19 to 28. Once operationalized, the intention is to leverage that ad hoc committee to identify interim and ultimate operating models, identify possible sites or one or multiple sites, and make recommendations on both of those things back to City Council. And is our anticipation that that will happen towards the end of the first quarter or perhaps slightly into the second quarter of this next year. Next slide, please. This slide lists the major milestones in the current scope of work, which includes validating the terms of reference in dialogue with elders and community partners, creating the ad hoc governance committee, which we hope will take place this month, and then early in next year, working on a retreat with the ad hoc committee to have some of those working conversations around the governance model, operating models, and shortly thereafter, focusing our conversation then on sites. And again, we understand that as this is a city-led project, that the ultimate decision-making body on those conversations remains City Council. We anticipate a conversation with City Council around site selection early next year, perhaps around February, March, and then closing out this phase of work on this project shortly thereafter. The additional phases of work that Council has funded in the CIP include additional site-based planning and design. However, that hinges on a site being identified and ultimately secured, which is something that will happen after this current scope of work and before the next scopes of work begin. And in that interim period as well, we will be applying for additional funding from other sources to support this work going forward. And that's my presentation for this afternoon.
Thank you very, very much, Mr. Stein. Just my question is, are you experiencing, I mean, as the process goes along, are you experiencing any roadblocks right now, or is everything kind of going fluidly right now?
The biggest challenge that we've had so far is that there was a bit of a delay between the last stages of the previous work, which was that feasibility and study and governance guide, and going through the CIP process to the point that we're at now. So we have reached out to those organizations who've had significant turnover and providing them with a greater depth of background information to help them more comfortably and confidently participate in the project. Like I said, some organizations have had staffing change, some have had leadership change, and so that's a bit of that education that's happened to bring people to where we're at now. I would say the level of enthusiasm in this project is as strong as it has ever been. Our partners who we're engaging are enthusiastic to be involved, to ensure that their voice is being validated and reflected in the work that we're doing. And so I would say it's going as smoothly as it could be hoped to be going.
That's fantastic. Thank you very much. Any other questions for Mr. Stein from the committee? Councillor Chatty?
Sorry, Mr. Chair. That's the reason I didn't want to be chair. It allows me to be more chatty. Thanks, Mr. Stein, for that. Sorry, I just ate a potato chip. Mark, I thought you were going to ask more questions. Through you, Mr. Chair, to either Perry or Mr. Dalton. I'm just looking at the timeline. I appreciate all the information, the update. But looking at the timeline, and council did just retweak our capital improvement program timeline. I just want to ensure that is everything still lining up so that council would have a project, not that we can't look at things outside of a CIP, but just wondering if everything is still on an appropriate timeline for council to consider.
Are you aware of any issues there, Perry? I'm not.
I hope I understand the question. I think I understand the question. Things are on the timeline that we had anticipated back when we put the CIP ask in last spring. Nothing has deviated too far from that. So the biggest kind of timeline variable that we're playing around with right now in the back of our minds is the federal funding cycles, because we are anxious to get as much money from them as we possibly can. And they've been very interested and are funding portions of the current scope of work, and at that time expressed a lot of interest in continuing to be involved. So we're keeping them in the loop as we move forward, and that's the only kind of timeline funding variable that I'm aware of that is impacting us at the moment.
Okay. No, thank you for that. I just couldn't remember. We had rejiggered the operating budget and CIP to sort of go hand in glove. And so I just wanted to make sure that it would still be there for that timeline. But I think it is, but I just wanted to make sure. Thank you.
Any other questions? I see none. Thank you for the presentation. I have a resolution from Councillor Palladino. Be it resolved that the Cultural and Social Standing Policy Committee receive the report regarding the Indigenous Cultural Centre Governance and Operations Planning Update as information. Call the question. Question's been called. All in favor? Anyone opposed? No. That is passed. We'll move on to our submissions, and I understand Mr. Fox is here and would like to introduce the Social Service Integration Committee.
Yes, thank you very much. Through the chair, I'd like to introduce the Social Service Integration co-chairs, Josh and Monica, and also here to support them as the backbone is Michael Bowe. He's part of the Community Social Development team, and they've been working very hard over the last little bit. And although they don't have a presentation today, they would just like to introduce themselves and the committee where this is the first time in front of an SPC.
Thank you very much. Thanks for being here. I know it's not a presentation, but maybe take us through the work you've been doing and how you've come to a couple of the suggestions that are coming up before us here today.
Absolutely. Thank you very much. My name is Monica Lowen. I'm one of the co-chairs, and as you see in that letter, we have a number of groups within our community represented. I'm here representing the faith community as a pastor at eFree. Co-chair is Josh Marty, representing the real estate community in Avison Young. As you can see from that letter, we are well represented, a well-rounded group of the community. And we've been working for about 6 months now, learning to gel together and work together, and have appreciated the support of city administration as we work to really discuss some of these very important issues within our community.
Yeah, and so we've been working on dealing with our primary mandate to, sorry, if I can speak without a mask, to be able to locate social services within our city, and we're dealing with long-term and short-term, situations as they arise. And so obviously with this winter, our priority has been to deal with some of these issues, especially when it comes to the shelter capacity as it stands here today. So our first recommendation to the SPC that we'd hope for you to recommend to council would be that we recommend that we entertain this emergency shelter space with the great news of the government funding of that $21.5 million. Just because we have capacity issues with the existing shelter, COVID restrictions, we're just not able to handle the population of the homeless folks here in our city. So we'd like to find a 4 to 6 month emergency solution that would handle this right away, and we've been privileged to have good weather so far. But our primary or our secondary recommendation here is still focused on the sober shelter component. And I know that this emergency funding is supposed to be all-inclusive, but this sober shelter is still something we want to focus on. And not just because we've had applications from previous applicants like the Mustard Seed for a sober component, but because word on the street, or if you want to talk with the homeowners associations or the Sage Clan, is that there is a huge demographic that require this service, and this demographic is the most closely able to be in the workforce and be a contributing member of society. So we want to recommend that we find funds within the city to be able to find a sober shelter that would be working in conjunction with the soup kitchen to provide meals together. So our preference would be to see the Civic Curling Center or the Park and Ride as a secondary facility be utilized here right away. And then our third recommendation would be, is more on the long-term solution to create a community care campus. We've tasked Marty Thompson to start working on the business case for that. So they're going to bring it back to our committee here early in the year, and then we're going to see if we want to be able to work hand in hand with the city administration on making that business case for a long-term placement.
When you talk about the $13 million the government has, is that what you said?
No, it was the recent announcement, as Michael would know more about the provincial funding for $21 million towards emergency shelter services.
So that $21 million, is that available, or does that have to be applied for?
Through the chair, there is some standards that we have to follow to get the money. The money actually is funneled through Alberta Health Services to existing operators, and we've been researching that, and we'll be bringing some news to council in a very short order.
So specific amounts of money have not been allocated yet to Lethbridge.
Correct.
Okay.
Lethbridge was one of the cities identified, though, to receive a portion of that funding.
So that's money that's available to all of Alberta, I assume, then? But
there was several locations highlighted in the press release.
Just on, I mean, I know that it's been contentious over I remember being here till midnight the one time, but which, it started this whole process of what we're doing here. So maybe take us through that whole process that you've experienced, and try to, getting everybody on board for all of these situations that we're in, and maybe give us a sense of what that's been like.
Yeah, absolutely. So I think the Mustard Seed hearing was an impetus for a lot of people to get involved, namely me as a realtor that was representing the Mustard Seed for that application. So through this process, as we've brought in all the different stakeholders from the faith community, service providers, homeowners associations, business community, it's forced, to have all of us in one room and start, bantering out and figure out, this whole NIMBY aspect and how to actually break through some of these barriers. So, and some of those initial dialogues were pretty tough initially, but I would say in the last 2 or 3 months, we've started to hit a stride where we're actually finally, working towards certain solutions here. So as we get into the long-term piece of maybe making land use bylaw recommendations, transitional zonings, however that looks, I think we're starting to see a lot more consensus amongst everybody that was opposed initially. Yeah.
Did you have anything you wanted to add?
I think just I would like to thank the former council for tasking this. I think it's very, very valuable for the community to have a voice. That was what was heard with the mustard seed, was people feeling they weren't heard. And like Josh alluded to, we had a few tense meetings. You take all of these voices and throw them in a room. But man, it's been valuable. And I think as we work together, that goal of a better city is really starting to come together.
Councillor Carlson.
Thank you, Mr. Chair. Thank you, Ms. Lowen and Mr. Markey, for your letter and the introduction. I bet it has been challenging. It's, I mean, but one thing I think Chair Campbell alluded to is we heard loud and clear that everyone who came out to talk to council knew we needed solutions. They just didn't know where, and they just didn't know how. And so hear you talk about combating NIMBY, I think is brilliant. Maybe to you or maybe to Mr. Fox, the committee, the SSIG, is that correct? I think that's right. Has identified two options or two locations. Are there others that could be or should be considered, or are we down to two?
We started off by looking at the two main zonings that would allow for a shelter, which would be the downtown district as well as public buildings. PB would be out because they're all going to be located against schools, neighborhood or residential districts. So we looked and narrowed down city-owned sites within the downtown core. We drilled it down to 4 sites, which was the Civic, the Bowman, the Park and Ride, and then the Multicultural Center. With the existing users of the Multicultural Center, that was ruled out fairly quickly, and we scored the final 3 selections, with the Civic being our top choice and the Park and Ride being our second.
Okay, thank you for that. And Mr. Fox is, oh, sorry.
Yeah, if I may add just another thing to that is, if the committee would like to recommend to city administration, we can look at the feasibility of the curling club and the Park and Ride as a temporary sober shelter, but we could also explore and report on any other possibilities through Opportunity Lethbridge.
Okay, excellent. Thank you for that. Can you help me out with the business case for the community care campus? Could somebody give me a bit more of an overview on what that would mean? And not just what the business case would mean, but what the community care campus would mean.
Yes, Your Worship. And City Council members, the coordinated care campus has been developed in several different municipalities. I think Grand Prairie's one, and out east. So we've looked at hiring a expert consultant, Ian DeJong, to look at building a business case specific to Lethbridge, and looking at more of both incorporating the Indigenous community and then just the specific areas in and around Lethbridge, and then utilizing that in conjunction with Opportunity Lethbridge to see if there would be a business case for a coordinated community care campus. It's it is co-locating like-minded services in the same area to help with the recovery continuum and that housing continuum, to better place everything and make it all work in a more finely tuned manner.
Thank you for that, Mr. Bowe. Did you say, was it Ian DeJong? Was that the name you mentioned?
Yes. Yes, it was, yeah.
Okay, I think I've worked with Ian in the past. We did some work on pathways to homeless or out of homelessness. So awesome person. Part of that business case, Mr. Bowe, you might want to stay there. Would that also be site selection or possible site selections, or is it just the business case regardless?
It's mainly the business case, but there is the opportunity to be able to have Opportunity Leverage look at possible locations and see if there's any that would match that business case.
Okay, and thank you. And just because we talked about some of the roadblocks of where these types of services or facilities can be located, are there any roadblocks to this campus care facility?
I think the roadblocks would be with any social service. It's getting the zoning, it's getting the community to back it, and I think with the social service integration group, the amazing work that they have done the countless hours, the over 50 hours that these individuals have put into this is really shows their dedication as a community. And so I believe that a lot of those barriers and challenges the SSIG has identified, and I'm sure that those are ones that will come out of those meetings as how to be able to get these social services in the right location.
And final question, if I can, Mr. Chair. One of the challenges for these types of service, I guess I'll just call it services, is that finding a spot, sometimes challenging, finding the capital funding, sometimes challenging, but those are easy hurdles. It's the ongoing, who is taking care of it, who is funding it, who is overseeing it. Is that going to be part of the business case and we look at different types of models, or we just settle on one? Or is that a little too early to even discuss?
It may be a little too early to discuss, but I believe that the strategy is to look at a made for Lethbridge solution, that it would have to be a coordinated care campus that is specific to Lethbridge, not a copy and paste from Grand Prairie or any other municipality.
Okay, thank you. Thank you, Mr. Chair.
Mr. Fox, you wanted to chime in?
Yeah, I just wanted to say we have been having lots of close conversations with the province, and a lot of the services that may co-locate at a community care campus type location, the ongoing funding, the province has said that they would be very interested in that model and looking at opportunities to fund it as well. So those conversations have started, and we are talking about all the different types of services that are needed here in Lethbridge.
Thank you. Our newly activated advocacy committee may come in handy. Thank you.
Councillor Schmidt-Rempel.
Thank you very much, Mr. Chair, and thank you very much for your presentation. A couple of questions, and I'm not sure who I would address these to. When we're looking at the two facilities that we have here right now that we're looking at, has any community engagement been undertaken? When will that, what does that look like? When will that happen?
I can take that one if everybody's good. Through the chair, those right now are suggested from the SSIG, so the only communication has been internal, and that's why I would recommend that we look at the feasibility internal through administration of those two locations, and also look at exploring and reporting on any other possible locations to council, and then we would have to follow the proper process through zoning and through the regular government processes to allow that, and that would include a very vast public communication.
Perfect. And one other question. In our packages here, we had the sober shelter / soup kitchen. Is that an additional soup kitchen to what we already have, or are we relocating our current soup kitchen?
Through the chair, again, I would be separating the two items at first and looking at it, although the group at the SSIG has looked at it and is recommending something that it would be co-located. But really, a soup kitchen isn't necessarily sober. It's more based off of the activity that is performing. So it would depend on how it's divided from the sober shelter and the location that it would be in, if those two activities would be well co-located. Most shelters do provide some type of soup kitchen type function. They do provide food to the people that are staying there, but it's not always necessarily that they're co-located.
So just to be clear, we're not talking about relocating what we currently have for a soup kitchen. This would be an additional one? Sorry.
Can I jump in there? I think we don't know that now, but I think what we do know is when the Mustard Seed was here previously, that the soup kitchen had indicated their intent to move and co-locate with the Mustard Seed. And we know at that time that there were conversations with the current shelter operator about backfilling that capacity. So that's really in the hands of the service provider, and that would be, I think, information to come.
Thank you.
Any other questions for anyone? Mr. Dalton, did you want to add something?
I suspect you were going to do this, Mr. Chair. I just wanted to thank the working group for the work that they've done. It's been absolutely phenomenal. And I just wanted to highlight for the new council members that this was a very new approach, as mentioned. But it's one I think we want to leverage even further going forward, because we know these are difficult discussions. We know we need as many perspectives as we can get from across the community, not just when solutions are proposed, but in developing those solutions. So I know there's a long, long way to go. And I know it may be other individuals that step in because you have real lives and real jobs, but I just want to say how grateful we are for the work that you're doing and the work you're collaborating with us on.
That's exactly what I was going to say. Do you, this, going forward, if we approve the resolution here, this goes to council, you want to get this activated pretty quick since it's getting to be winter time, I assume.
Yeah, through the chair, we would be taking action, and we have currently been working behind the scenes on some. But again, in supporting the SSIG and the work that they've done, I believe these resolutions will help us move forward in a timely manner and get them the information they need to continue the good work they're doing.
Great. Any other questions here? We'll look at the resolution. Thank you again. Thank you very much for your time and all of the work that you've done. And it's you know, an issue that we've got to deal with. So I appreciate you coming before us and making some recommendations. Thank you. So I'll give this to Councillor Carlson. Be it resolved that the Cultural and Social Standing Policy Committee recommends City Council direct City Administration to collaborate with Alpha House and the Government of Alberta to identify immediate options for a 4 to 6 month emergency overflow shelter, and 2, City Administration to evaluate and report on the feasibility of using the Civic Curling Centre or Park and Ride facility as a temporary sober shelter, and also explore and report on any other possible locations, and 3, City Administration to develop a business case for a community care campus, including site location. Councillor Carlson.
Thank you, Mr. Chair. I would like to add a further be it resolved.
Okay.
That Ms. Lowen and Mr. Marty and their, is it a committee or is it a working group? I think it's a group, be thanked for their presentation, as well as all the effort to bring us here today.
Okay. I can accept that. Mr. Westerson, you got that in there? Okay. You'll have it up there. You took Evelyn Wood course, didn't you? Okay. Crickets.
The sly brown fox jumped over the lazy dog.
We're just getting the resolution just to reflect what Councillor Carlson had. Is there any other comments or comments on the resolution from standing committee members?
I have one question, Mr. Chair. If I might, I probably should have asked during the presentation. Winter is upon us, and I know that the resolution contemplates immediate options. We don't have another council meeting for 2 weeks. How immediate do we need to be? We always have the ability to call a special meeting to get something approved. I know that the committee cannot give direction to our staff and administration. This lays in the purview of council, so it is a recommendation, but it is 2 weeks out. And I noticed that the word immediate was mentioned several times. So maybe to Mr. Fox from Mr. Dalton.
Mr. Fox?
Thank you for the question. And through the chair, we have been working with the province where this does lie on the province's responsibility. They have came forward and provided us with some good information, and we continue to work with them on the immediate issues. And you will be informed on those at the next council meeting. Okay,
great. Thank you then.
So the resolution is as read and also with the amendment. So I'll leave it with you, Councillor Carlson.
Thank you, Chair Campbell. Just to echo, I appreciate the work that's been done. This is a Apparently this committee likes the big hairy issues, or at least gets the big hairy issues, which I think is good. It's good to tackle those, and especially good with the support of community members, like the folks that are in front of us today, as well as their group. I think we need to take action on this sooner rather than later. Immediate is a good word, so I appreciate that being in there. And I would just ask for my colleagues' support that we take this to council to get that immediate action and approval as soon as possible. Thank you.
Question's been called. All in favor? That passes unanimously. Thank you again for your time. Thank you. Final item on the second last final item. Confidential items from Councillor Palladino. Be it resolved that the Cultural and Social Standing Policy Committee direct that the closed meeting discussions, reports, documents, and presentations with respect to the external organization update remain confidential pursuant to Section 16, harmful to business interests of a third party. 23, local public body confidences. 24, advice from officials. And 25, harmful to economic and other interests of a public body of the Freedom of Information and Protection of Privacy Act. Councillor Palladino. Question's been called. That passes. Oh, okay. Councillor Carlson, do you have a question? Sorry.
Thank you, Chair Campbell.
That passed, by the way. Yeah.
Something I wanted to bring up when we were discussing the consent agenda, and I've mentioned this at every SPC that I've been in attendance at the end of last term of council, each of the SPCs provided a term end report of the work that had been done and the work that was ongoing and necessary or should be continued or was recommended to be continued. I just want to say that we should provide those reports to the members of each SPC just so they can familiarize themselves with the work that has been done and the work that is ongoing. So I just wanted to see if we can ensure that happens.
Sure. Who would be? Mr. Westerson will provide that.
We'll take care of that.
Thank you.
He'll take care of it. Perfect. That leaves us to our final. It's all over. Correct? Adjournment. Thank you all. And good night.
Thanks all. Take care.
Thank you.